epidural fistulas because they are the most common ones, and they do share several common characteristics. Now, when we think about spinal vascular malformations, I remember since I started my training, one of the most confusing things for me has been to try to put them somehow together in an organized and rational way. And I do agree with, particularly with Dr. Spetzler and this group about the fact that probably the most rational way to look at this is that if we consider the anatomy of the spinal canal and its content, then as we go from the outside in, we can differentiate various types of shunts, arteriovenous shunts. And the focus of today's presentation is to focus on those shunts that are localized in the epidural epidural space. You will see that one of the most important differences is to differentiate these shunts from the more common so-called type 1 pure spinal dural fistulas. And as you can see in this artistic rendering, there are really two main types of spinal epidural shunts. There is one type that is, especially when we consider the lumbar and the sacral spine, because the ventral epidural space it's more spacious than other epidural compartments. These shunts, they often tend to involve the ventral epidural plexus. And then we have two types. One type is that there is through the emissary vein, there is what I would call and define a retrograde intradural venous drainage through the perimedullary vein and eventually to the coronal plexus. And it becomes very important to differentiate this particular shunt, as I said, from the most common true type 1 dural AV fistula. And then there is another type of epidural AV shunt, what I would consider almost like a paraspinal AVM, where often you have not a single direct shunt, but multiple shunting points with involvement of epidural veins because of the high flow. The epidural veins become congested, and as we can see, there is no intradural retrograde venous drainage. And as we will see, this type is different because often in this case we have compressive symptoms. Now, I also like to clarify that there has been some confusion in the literature, particularly because the so-called vertebral fistulas that often occur in patients with neurofibromatosis or can be the result of trauma have been included in the epidural spinal category. And that's the reason also why I will try to focus as much as possible on the lumbosacral type. Now, you might think, well, this is a quite esoteric topic. Why focus on a lecture on these epidural types? Well, the reason is that for whatever reason, they are becoming much more common. And if I look just historically what has happened here, Mayo Clinic, Rochester over the years, in 2009, my colleagues reported a series about 6 patients with spinal extradural AV fistulas. And this at that time was one of the considered one of the largest series reported. Only a few years later, Takai put together a review of the literature from 1990 to 2011 and was able to collect about 42 cases of extradural spinal AVF. But when we looked at our own experience up to 2016, we were able to collect, so we went from 6 cases in 2009 to 24 cases from our own institution. And since then, they've become more common. And this has been not a single institution experience. This has been corroborated by a multi-institutional series reported from Japan and Korea. So there is an increased incidence, and you wonder why. Is it because we are better at diagnosing these lesions, or there is a true increase in the incidence? I think it's probably both. And one of the reasons that it's not infrequent that some of these epidural fistulas are a delayed complication of spinal surgery. And if you think about spinal surgery, we do quite often, more commonly a posterolateral approach. We almost always encounter some degree of epidural bleeding. And what we do, we tend to pack or compress with hemostatic material. Sometimes if the epidural vein is immediately available, we coagulate directly. So I suspect it's possible that some of these shunts, especially iatrogenic, might actually be much more common than we think, and probably in the majority of cases asymptomatic and non-diagnosed. So as we will see, it's important to consider in a patient who presents months after prior, even simple uncomplicated spine surgery with the new symptoms, it's always important to consider this possibility that it's not that remote. Now, when we put together our cases seen over 18 years of spinal vascular shunts, excluding other vascular lesions like cavernous malformations, we had over 200 patients. And I was surprised to find out that, yes, the so-called type 1 dural AV fistulas are definitely the most common ones. But I was surprised to find and see once you start recognizing, you can see how we went from 6 to 24. And in 2018, 4 years ago, we were already up to 49 cases of epidural AV shunts. Now, here is something very interesting, is that if we look at the relative distribution along the spine of the, the different type of fistulas, we can see, sorry, in blue, the more common type 1. And you can see they are by far more common in the thoracic spine, less common in the lumbar and in the sacral spine. Well, if you look at the epidural types and you consider the ones in the lower spine, you can see the epidural spinal AV shunts that are represented in red are much more common in the lumbar and in the sacral spine. And even more interesting is that when we go and try to look at the different distribution between these two types. What we notice is that the type 1 dural, properly called the dural AV fistulas, they're not in the cervical spine. They are almost, they're exceptional. Of course, if you exclude the craniocervical junction ones, but that's a category on its own. They are much closer to the intracranial dural AV fistula. Now, as I said, the thoracic location for type 1 spinal dural fistula is by far the most common. But when we look at the ones that were in the lumbar spine, the vast majority were at the upper lumbar segments. And only one was below L3. While the converse is true for the spinal epidural types that are much more common at L4, L5, and in the sacral segments. So I think that as we start understanding more and we look more into these differences, I think that we'll understand more about the potential pathophysiology of these different two types. Now, when we consider the epidural shunt, as I said, we can separate two different types. One is usually a direct, simple AV shunt, usually in the ventral epidural space. And then we have this paraspinal AV fistula / AVMs. Now, when we consider the anatomy, as I said, the more common type is this shunt in the ventral epidural space. And often these fistulas are fed by dorsal somatic arterial branches of the intercostal, the lumbar, or ilioinguinal branches of the iliac arteries or the lateral sacral arteries. And that we will see will be very important in their correct diagnosis. The other thing that I like to stress once again is this relationship between the shunt and usually in the ventral or in the ventral lateral epidural space. And in those cases that have involvement, retrograde involvement of a spinal vein, it's usually through the emissary vein, which eventually in a retrograde, non-physiological way, drains underneath the ipsilateral pedicle, then retrograde through the posterior or the anterior medullary vein. And I would like for you to remember really this anatomical pathway, because as you will see, it's often a common thread when we do the AP angiogram to recognize some of these AV shunts. When we look at the symptoms, then we have, again, two types of fistula from a clinical point of view. There is one type where the symptoms are related to the secondary intradural venous drainage. And therefore, in this case, symptoms are not that much different from the more common type 1 dural AV fistula. And this is a classical example. And you can see another thing is that on MRI, the radiological typical finding, T2 changes, which almost unequivocally extend down to the conus, presence of flavoids that may or may not be as prominent as in this case. And when we do the angiogram, I will continue to stress the fact that that's how you can simply differentiate between the epidural shunt, where the shunt it's into a venous pouch, usually in the ventral epidural space, as opposed to the typical type 1 dural AV fistula, where you see the artery that starts tapering down, and then you might see a tiny little nidus, and then you might see a larger vessel indicating the vein. In the epidural AV shunts, you can see that there is a shunt that is into a pouch, and then in a retrograde fashion, you can have involvement, and here you can recognize the typical course of the intradural perimedullary vein that forms the coronal plexus. And then we have the other type, which is less common, and this is quite often is the one that you may see as a delayed complication of spine surgery, where the symptoms are compressive symptoms related to engorged veins in the epidural plexus, veins that are engorged because of the secondary effects of the high flow. And this is an example, and here you can see, you see better in the sagittal, you see that this patient has developed stenosis, but the stenosis is secondary to an exuberant venous plexus. And here you can recognize a large foraminal, abnormally dilated foraminal vein. So these patients present with compressive symptoms. In this case, I think it was mostly radiculopathy. So the diagnosis, again, nowadays, usually these patients, they come in with an MRI. And as I said, if you have a retrograde venous drainage, spinal venous drainage, the findings are really impossible to distinguish from the classical, more common type 1 dural AV fistula. Something that we have noticed, and others have also made the same observation, is that especially if you have a sacral epidural fistula, on the MRI as an indirect sign, you will notice in particularly enlarged vein going and coursing along the phylum terminal. Of course, this is a obvious case, but sometimes you might not have intraspinal flavoids. You don't have T2 changes, and the only indirect sign in a symptomatic patient is that if you pay attention, you may see this enlarged vein running along the phylum from the sacrum up. Now here you can see that again on angiogram, the classical finding is that you see a shunting into a pouch. And again, and over, I will stress the fact that this is a typical finding, and that's it's a major clue that the shunt is in the epidural space. And only secondary, you see the typical retrograde intradural vein. That's how you differentiate the two types of shunts. And I suspect that in the past, many of these epidural fistulas were indeed classified under the umbrella of the more common type 1 dural AV fistula. And only after several groups started bringing up their characteristics, they became more commonly recognized. Of course, the cone beam CT is very useful. Here you see nicely, you see the somatic artery going directly into a pouch, which is on the ventrolateral epidural space. MRA has been, I mean, we use it, and the main reason, not the main reason, but the main clinical utility that we found on MRA is that, as you know, in many of these patients, they are in their 7th, 8th, 9th decade of life, and they have atherosclerotic disease. The spinal angiogram can be quite challenging. So we use really the MRA as a guide so that we can start a spinal angiogram at those segments where it's more likely that we are going to find the fistula. So in a way, we use the spinal angiogram for the most part as a screening tool. Now, I must say that as we became more and more familiar with these epidural fistulas, then the spinal MRA and has been very helpful because you can quite often identify the level of the shunt and see the dilated venous shunt. So once again, the hallmark of the majority of this fistula is the presence of a venous pouch that gives you an important clue to the fact that the shunt is indeed in the epidural plexus and it's not directly into the dural intradural vein. Here is an example. Here is iliac catheterization and the selective I think it's an ilioinguinal branch, and you can see that often these fistulas, it is said that they have multiple feeders, but the truth is that here what you can see, you see the anastomosis between the two sides along the midline, and then you can see the venous pouch, and then remember the emissary vein that goes around the pedicle, and then only secondarily gives rise to involvement of the intradural vein. So this type of course of the venous of the pouch then into the emissary vein around the and underneath the pedicle, it's also another fairly common characteristics of these epidural shunts that have secondary intradural venous involvement. Just a brief practical digression here is that, as I said, I think in the past we didn't have this fine detail, and we would see the intradural vein, and some of these were categorized under the type 1 spinal dural AV fistula. And I think that probably this is one of the reasons because to justify, to explain the fact that if you remember, years ago, it was not that uncommon to see occasionally a quote unquote recurrence after ligation of the intradural vein from a surgical perspective. And you can understand why, because if you treat this fistula as a type 1 and you do intradural ligation of the proximal portion of the draining vein, you actually leave the shunt, the actual AV shunt in place, and unless the shunt is isolated and there is no other drainage because the surrounding plexus has thrombosed or it's functionally occluded, then you might have a shift of and recruitment of an intradural vein at the level above or at the level below, or at the same level but on the opposite side. So I suspect that some of those rare surgical recurrences that were reported after operating at the correct level were probably related to misdiagnosis of a dural fistula from what indeed there was an epidural type. Now, if we consider this picture, it's also very important to discuss, well, if we do a endovascular approach, do we really need to fill the proximal portion of the intradural draining vein as we are taught to do in order to cure a type 1 dural fistula? I personally think that it's really not necessary. The key is to completely obliterate the actual AV shunt in the epidural plexus. If you get embolic material into the proximal portion of the secondarily involved intradural vein, I would say that always say that's a plus, but in my experience, it's not something that it's absolutely necessary as long as you obtain complete obliteration of the actual AV shunt in the epidural plexus. Another aside that is important, some groups have reported surgical treatment of these fistulas by simple obliteration of the intradural proximal draining vein. And I think that's a treatment that it's effective in many patients in helping with sorry about that.
To ensure everyone's safety, we require that patients, visitors, and staff wear a face mask that properly covers.
Sorry about that interruption. So I was saying it's an effective way in many patients to treat the symptoms, but you leave the shunt in place, and in some cases you might have a recurrence by recruitment of another intradural vein at the level above or the level below. So here again another example, and you can see that now you start recognizing the pattern and say, oh wow, like that makes a lot of sense. There is a venous pouch. So here is the shunt, and then there is secondary involvement of the emissary vein, and then retrograde intradural vein. And you can see how some of these patterns, they tend to be fairly consistent, and they relate quite well to the anatomy. Now, here is, as I said, that there is the direct AV shunt in the epidural plexus, and then you have this paraspinal AVF, AVMs, where the symptoms are related to abnormally engorged epidural or foraminal veins as a consequence of the high flow. And you can see that here, this is obviously, many of these are obviously completely different situations. Like in this particular case, you see that there is almost a giant direct main AV shunt with multiple secondary epidural and paraspinal veins involved. This is a patient that was treated the same way we would treat a direct PLAV fistula, with direct occlusion of the AV shunt at the junction between the arterial and the venous system. So again, when you start going into the paraspinal AVMs, VF, that's a different situation than the other epidural with the secondary retrograde spinal venous drainage. Now, What we have noticed is that it's surprising us less experienced colleagues, when they do the spinal angiograms, either don't include internal iliac injection, or if you have an internal iliac injection, the contrast is very diluted, and even if you have a fistula, you might have a hard time to see it. And that's something that definitely we have seen ourselves in our practice, where only a very high index of suspicion and the multiple repetitive injections eventually led to a recognition of a very faint opacification in patients with these fistulas. And you know that many of these patients, unfortunately, the correct diagnosis is delayed for a variety of reasons. And of course, the prognosis is often affected by the length of time between symptoms onset and eventual treatment of the fistula. Now, as we start paying attention to what we were seeing, we saw a patient with a epidural fistula with the spinal AV shunt and a neural tube defect. And at first we thought, wow, that's an interesting combination. And we thought it was probably due to chance. And then we saw another patient. And then, of course, there is nothing new under the sun. We'll start looking at the literature. And sure enough, there were here and there sparse reported cases of spinal vascular malformations in patients with the neural tube defect. So over the years, we start seeing more than one, and we noted an increasing number of cases reported in the literature. And eventually, we're able to put together 6 cases that we have seen. And we were able to demonstrate, also putting together other cases reported in the literature, we were able to demonstrate a true association between these two conditions. So, one thing is that, spinal dural fistulas or epidural fistulas are very uncommon lesions, and neural tube defect is also very uncommon. So once you see a coexistence of two rare diseases in the same patient, then of course we should, as much as possible, try to find a potential connection between the two. So what did we observe? We observed that all cases were epidural fistulas. At least in our experience, were all fed by the lateral sacral artery. All of the patients that we have seen had the epidural fistula with the secondary retrograde intradural venous drainage, and the type of neural tube defects we observed were different. So up to this point, we thought, well, that's probably easy to explain. These patients, they have surgery at the very early age, and we are all familiar with the extreme angiogenesis that is present, especially in the first few years of life. So we thought, well, there is surgery, there is a trauma with surgery, you often cause some bleeding, and there are micro shunts, and eventually over time, these micro AV shunts, they can evolve. So this is one of such a case. You can see tethered cord And this is a direct AV shunt, and you can see here the feeding artery, small nidus, maybe a venous pouch, and then the retrograde vein. And then we saw a patient that actually never had the spinal surgery, and I will show it. And we ran across this report of a patient where actually the formation of the spinal dural fistula was demonstrated over time on subsequent MRIs done for different reasons in a patient who never had surgery. And we also had such a patient. This is a patient with the tethered cord, the low-lying cord. There are T2 changes in the conus. You see that the patient has a split, also a split cord malformation. And you can see here, this is the fistula in this particular patient. And if you look at the onyx cast, the arrow is pointing to the actual point of fistula, and you can see that the AV connection was right in the ventral epidural plexus. So our hypothesis that some of these cases were related probably to early surgery was obviously incorrect. And for whatever reason, and this probably has to do with the genesis of commonality between the genesis of neural tube defects and spinal AV shunts and the possibility of an arteriovenous shunt, there must be some commonality that, of course, still eludes our ability to fully understand. But this is something to be cognizant, because in a patient who has a known neural tube defect, progressive myelopathy or progressive new symptoms might not necessarily refer to progression of the original disease, but might indeed be related to an underlying AV shunt at the level of the epidural space. What about treatment? Well, it's becoming not uncommon on spinal angiograms done for whatever reasons. This is seems to be particularly true for the cervical spine, that we see epidural shunt in patients completely asymptomatic, usually an incidental finding on angiograms. These shunts are so small that it's very difficult to see on non-invasive. And of course, if the shunt is incidental, there is no retrograde intradural drainage. The shunt is purely epidural. Then we feel comfortable observing these patients over time. Now, surgery, of course, traditionally was the mainstay of treatment, particularly because of our inability to provide this fine distal catheterization that is commonplace today. But the surgery, it turns out, it can be quite challenging because, as we saw, most of these shunts are located in the ventral epidural space, and from the typical posterolateral surgical approach, it's very difficult to completely expose the shunt. There can be brisk bleeding that it's not always easy to control. As I mentioned before, in very selected cases, surgical interruption of the intradural secondary connection can be a reasonable alternative in symptomatic patients, but there is no question that endovascular therapy is the therapeutic option of choice. And this is in opposition to the most common type 1 dural AV fistula, where, for good reason, it's still debated whether surgery is even today a better choice than endovascular therapy. The other thing about endovascular therapy we have observed in this specific type of fistula is that because of the high flow and because of the anatomy of the vessels involved, it's very easy usually to achieve a very distal microcatheter position very close to the point of fistulization. And because of the high flow, as you start pushing the embolic, the liquid embolic material, there is often distal progression into the proximal portion of the venous portion of the shunt, and without getting too much reflux, especially if we are using onyx or similar materials in the early phases of the embolization. I'll show you a typical case here again. A patient, as I said, from a symptomatic point of view, from an MRI imaging point of view, it's very impossible to distinguish an epidural fistula in the ventrolateral venous plexus from the more common type 1 dural AV fistula. So here is a brief video so you can see iliac artery catheterization, and then super selective, you can see the micro wire, you can see the micro catheter, super selective catheterization of the feeding artery, and you can see that there is the shunt into the venous pouch. And as I said before, it's not that uncommon that with modern endovascular techniques, you can really reach a very distal microcatheter position, very, very close to the actual point of AV shunt. And you can see here again the typical arcade that by now you have memorized, and here is the feeding artery. And you can see here a secondary venous drainage, and here is the onyx cast. And as I said, the key here is to be able to obliterate the epidural shunt. Whether or not you get much, you can see here, you can start seeing some proximal involvement of casting of the distal emissary vein. I think that's a plus. The key here is to obliterate the shunt in the venous plexus. Now, of course, my very skilled colleague, Dr. Bringigi, as he started doing a lot of venous catheterizations, has been able lately to embolize some of these fistula going through a retrograde venous transvenous approach. And I think that that of course adds a nice alternative approach, especially when you have this situation, and this you can recognize immediately. This is the type of spinal epidural fistula with involvements paraspinal AVM/AV fistula. You can see here combination of coils and onyx through a combined transvenous, and you will see later eventually a transarterial approach to finish. You can see here retrograde filling of some of the paraspinal and epidural veins that were utilized by this purely extradural fistula without intradural venous involvement. So in conclusion, spinal epidural fistulas are increasingly recognized type of spinal AV shunt. The lower lumbar and sacral segments are more commonly involved, as opposed to the preferentially thoracolumbar involvement of the type 1 dural AV fistula, with the caveat that when the lumbar spine is involved, usually for the type 1, the first 3 lumbar levels are by far the most common ones. The shunt for epidural fistulas is often at the level of the ventral epidural plexus, and they can be commonly retrograde intradural venous drainage that is responsible for patient symptoms. Important to keep in mind that these AV shunts, and we're seeing this increasingly, can occur as a delayed complication of prior spine surgery. And there is now, I can say, a fairly established connection between spinal epidural fistulas and neural tube defects. And once again, thank you for giving me the opportunity to discuss some of the mostly practical observations and practical things that we have learned over the years, dealing more and more commonly with this type of AV shunts. Thank you again.
Thank you very much, Professor. You can stop sharing your screen. The presentation was amazing, so thanks so much. Dr. McDougall, you want to start with any comments?
Yeah, first I just want to agree that I always love it when the presentation is so lucid that you said there's nothing new under the sun, but there's certainly new things for us to learn, and I learned a lot this morning, so I really appreciate that. I just wondered a couple of things. First of all, we always talk about the embolic agents. You're pretty much exclusively using onyx when you're embolizing these. Any NBCA?
Yeah, for the epidural, we tend to use onyx, and because we can usually get very close to the point of fistula, and I like the onyx because it's a little bit more forgiving, and of course, we tend to have more experience nowadays with onyx. Than we went back though and started considering and using glue for the type 1 dural AV fistulas, where often we are not distal enough, and we learned that the best chance to be able to occlude the shunt is to use glue instead of some of the more recent or modern liquid embolic agents.
Presumably in that case, a fairly dilute glue.
Correct.
Yeah. One of the things it was always kind of intimidating about the type 1 fistulas, I'm just wondering if it's the similarity here. They were intimidating because, as you mentioned, they're often older patients, difficult spinal angiograms, and it used to be the dogma that you had to do the complete spinal angiogram, cervical all the way down to the iliacs in every case to be sure there weren't secondary shunts or more than multiple levels. And I think you alluded to that some of the recurrence and things maybe just because we didn't appreciate exactly where the shunt was, epidural versus the intradural. So I'm wondering a couple of things. Is one, how focal is your spinal angiogram once you've sort of localized on MR? And how are you following these up to check that there aren't recurrences?
So that's the question about how focal is the spinal angiogram. It's a very important question, and we always go back and forth trying to be as comprehensive as possible versus identifying the fistula, knowing exactly where the Adamkiewicz is, and then make sure, of course, if we're thinking about any form of embolization, that there are no major spinal arteries emanating from the adjacent to the main feeding artery. So I think that we try to be as comprehensive as possible. At the same time, as you mentioned, you have to be practical. Once you find the fistula, sometimes you have to stop because the amount of contrast is already quite important. Or many of these patients, the spinal angiogram is very challenging. But the other thing we have learned that there is a particular type of fistula, which is the fistula of the filum terminale, where it's not, that's the only time where I've seen more than one fistula in the same patients. For whatever reason, those fistula of the filum terminale, they can be associated. And we have seen that in association with the typical conus perimedullary AV fistula and with a type 1 dural AV fistula. So my message is try to be as comprehensive as possible. I also warn that we have seen several fistulas that were not correctly diagnosed because many of our colleagues, they make the mistakes of starting intracranially. And because that's, again, was one of the classical teaching, but that refers to the tentorial dural AV fistula that can have, retrograde, so it doesn't apply. But otherwise, for the spine, we try to be as comprehensive as practically possible.
Do you find that pouch, which is a great sort of tip to sort of target and the clue on the MR that it's epidural, is the supply to the epidural fistula always at the level of that pouch, or can it be a level or two above? How consistent is that relationship if you're trying to minimize your catheterizations or in a difficult patient?
I would say that once you identify the actual pouch connection, it tends to be very, very consistent for this type that is mostly in the ventral epidural plexus. These fistulas, they can have they can be fed by multiple levels, usually through anastomosis, but I don't think that for this type that is the one associated with the retrograde, we have seen multi-hole fistulas. The paraspinal ones are obviously different, but this particular type seems to be very consistent, and that seems to be the main source of but that also does not, considering some of the potential recurrences that we have seen after simple intradural occlusion of the secondarily involved draining vein. The fact that that's what you see angiographically does not exclude that there might be other minor shunts that are just overshadowed by the big one.
Right. And so the follow-on question, just two things, and then I'll let Matthias have a chance here, is the follow-up of that. So do you do a delayed angiogram to make sure there hasn't been a recurrence, that there weren't some little shunts that you missed, or are you happy enough just to see the resolution of edema on the MR?
Yeah, what we have learned that if on MRI you see flow voids, the resolution of the flow voids, it's by far the best indicator that the fistula has been closed. You can still have improvement or even resolution of the T2 changes on MRI and some initial improvement, but you might still have some residual fistula. From a practical point of view, as you know, the problem is that once you close that main feeder, then you assume that the fistula is gone, but you cannot really exclude that there might be tiny little AV shunts that are just beyond the ability of angiography to identify, especially in the acute phase, once you have closed the main supply. But this is also the reason why I tend to do a lot of surgeries, especially for the type 1, for that specific reason. You have patients that are have progressive symptoms, they live far away. You don't know how compliant they're going to be with follow-up. And then that's really one of the main reasons in our shop to consider surgeries, because we want to give that patient the best possible degree of certainty that the fistula is closed. Because as you know, with embolization, once you obliterate that, and the other thing, the liquid embolic agent, especially Onyx, you might get the impression that the pouch, the vein is filled, but the material coats the walls of the vein first, and then you don't know if it's completely filled or if there is still a microchannel. So that's definitely a major chance. But to answer the question, I would say if you have flow voids and on MRI you see resolution of flow voids, that's, we have learned, it's the best guarantee. Everything else, you cannot be absolutely sure.
And the last thing before I'll turn it over is the patients that are presenting with radiculopathy. What's does the radiculopathy resolve nicely when you embolize that pouch, or are you just creating mass lesions there, and should some of those be operated on?
Yeah, great question. And that I'm always worried. The clinical impression is that the radiculopathy improves. Now, the Onyx, in terms, if you think of consistency, is a spongy material. So it's almost like leaving gel foam in a way along the nerve root. So that's how I can explain the fact that, of course, as long as you don't use coils, that's different. It's tougher material. But the liquid embolic agent might create some secondary inflammation at first, but the symptoms, they tend to improve. The symptoms related to compression, particularly on nerve roots. And I think it's because of the consistency. It's like a soft sponge. It's not a sturdy, hard material.
Thank you. Really helpful, really lucid presentation. Really learned a lot. So thanks so much for that. Matthias, I'll turn it back to you. And if you have any questions or questions from the chat.
Yeah, so Professor, a question from myself now. I mean, the intramedullary, extramedullary, and the extradural venous plexus is like super redundant, and it's a big capacitance system. So why do you think these fistulas happen? I mean, there is so much collateral networks up and down and lateral. Why do you think they get engorged and like?
Yeah, I think it's I think it's a combination. I start thinking that maybe if you think about the relationship, let's think, if we think about esopathogenesis, why people have a fistula, then I start thinking that maybe given the characteristic and fairly typical and consistent location of the type 1 and the fistula, when you do surgery, is right underneath the pedicle, I start thinking, is it possible that this might be related to microfracture or microtrauma at that level? While the epidural ones that are in the lower segments, I've seen some of those, they are also traumatic. I've seen some patients that definitely had some major falls. And then the question is, as you said, well, the plexus is so exuberant and there are so many connections. But I think is that once you develop the fistula, and in those patients where you can recognize, including the surgical trauma, you can recognize the inciting event, the fistula and the symptoms do not appear immediately. There is always a lag time, often of months, sometimes years. And I think the reason is that, the fistula being a low pressure shunt basically sucks blood from everywhere. And over time, the flow increase, there is a secondary high flow venopathy. The high flow venopathy must lead to occlusion. And then you are left with the isolated venous pouch that the only way it can decompress is through the retrograde cortical. So I think that's how I explain. For the same reasons, if the fistula is slow flow, and we do see now more and more incidental fistulas on spinal angiograms that we do for other reasons.
Okay, good. And regarding multiplicity, I mean, there is more multiplicity of figures in epidural than in dural AVFs. So why do you think that happens?
I, you know, I don't know, but I think is that if you think about the area where the fistula develops, it's a larger relative area compared to a type 1 dural AV fistula. And so it's almost like an intracranial dural fistula. There is potential for different vascular territory to be involved, and also there are a lot of anastomosis, as you saw in the one of the video and some of the super selective injections. You inject the fistula, and then there is retrograde filling of the contralateral side. So I think it's I'm always wondering, and of course there are different variations on the same theme, but I'm always wondering, are we seeing truly multiple feeders, or it's in significant number of cases is just that we are seeing the multiple potential anastomosis that eventually converge into the same focal point.
Okay. And regarding location, I mean, we know that they are more located in the lumbar and sacral parts. Do you think it's related to also congestive venopathy? Because there is some association between epidural fistulas and obesity, for example, that I think you described.
Yes, I think that's probably, and we have also seen in patients that have DVTs, and I think it's once you develop venous hypertension, whatever the reason for it, then that might somehow lead to formation of AV shunt, same way that we see dural fistula developing after prior thrombosis of a dural sinus. So I think obesity, but any factor that promotes deep venous thrombosis or prothrombotic states for whatever reasons are potential inciting factors.
Okay. Did you find any difference between spontaneous epidural fistulas and post-surgical? Is there any morphological difference?
Yeah, the post-surgicals, they tend to be, you know, of course, they are at the site of the surgery, and they tend to develop, you know, become a high flow fistula that involve, you know, more different paraspinal compartments. The other ones where we cannot find an inciting events then seem to be more focal in the ventral epidural plexus.
Okay, Professor, how would you describe the evolution on follow-up of these patients after your treatments? Is it similar to dural AVFs?
Yeah, for the epidural, at the beginning, of course, we were very anxious and tend to follow them. So what we do is as long as the patient, if the patient is symptomatic, as long as the symptoms are the same or better, we tend to wait and we do a follow-up MRI with MRA after 3 months. And then from there, for the epidural fistulas, I must say that I am more confident, I'm becoming more confident that once you get a good initial result, it's stable over time, and you can be, I can tell the patient this is more likely than not taken care of. For the type 1 dural fistula, when we embolize, it's always in the back of my mind whether or not it was a complete obliteration or not. Those patients we tend to follow a little bit more closely for a longer period of time.
Okay. Do you have any experience with osseous, intraosseous epidural fistulas? There are a few papers describing osseous, non-osseous.
I cannot in the spine, I cannot remember definitely seeing one.
Okay, we have one more question here from the audience, from Dr. Summer Oz. He thanks you for the talk, and he asks, in multiple dural AVFs, he changes to dural AVFs, do you favor transarterial, transvenous, or is unrelated?
Well, I think, it's for multiple dura, if we consider spinal dural fistula, I would say that multiple lesions are uncommon. And at least the ones I've seen, they tend to be usually amenable to surgical treatment because they involve dural or intradural shunts. For the intracranial dural AV fistula, and it's not uncommon intracranially, you see, we tend usually to treat the larger one, and sometimes if you treat the larger one, you resolve the in venous hypertension, and the other ones, they become irrelevant or they might even spontaneously regress.
Okay, last question. What is in your mind the main difference between BVF and vertebral venous fistulas and epidural?
Yeah, the vertebral fistulas are I think are a category on different category, and because it's usually starts with a direct AV connection between the artery and the perivertebral plexus. So you can see spontaneously in patients like with neurofibromatosis, the typical in those cases, probably there is some underlying weakness of the vessel wall at that level. They usually tend to occur at the C1, C2 level, and that's, of course, it's a level where the artery itself, it's subject to a lot of motion twisting. They are also seen after iatrogenic traumas for catheterization. So I think those it's a different type. Of course, you can have the vertebral one. It's interesting because you can have secondary involvement of the epidural plexus, but it's a true fistula between the artery and the perivertebral venous plexus. And the other thing, that those are the ones where, interestingly enough, we don't see much, originally, some of the original papers say, well, epidural fistula can present with compression, they can present with myelopathy if there is retrograde venous, but they can also present with the still. You don't see still phenomena for the true epidural ones, except for the vertebral. So I consider the vertebral ones a category of their own.
Okay, great. Thank you very much, Professor. It was a really nice talk, very informative, and we really appreciate your presence here. I hope you join us.
Thank you. You can tell that's something that get very excited because it's one of those things where almost you can learn. Of course, we always learn from every patient, but this is something that it's knowledge in evolution. So, like you see something, you say, "Oh, how come I didn't think about this?" And it's one of those things. I say that it keeps what we do interesting, as long as you are keen to observe this minutiae.
Yes. Okay, thank you very much.
Your enthusiasm was infectious, and again, thanks so much for doing it.
Thank you so much.
Nice
Great to see you. Bye.
Bye-bye now.